Hi, everyone. Good afternoon. It's great to be here. Great to be here this afternoon. Thank you all for coming. If you had a chance to hear some of Dr. Marsh's remarks during lunch and the last question that was asked about how do we actually make this happen, that's a perfect segue into what we're going to talk about here for the next half hour or so. As you may know, President Gee has identified health as one of the three critical pillars of West Virginia University, and Vice President Marsh has articulated really a new vision for health for West Virginia. And the vision, as you heard, really emphasizes wellness and prevention. And there have been many people, and I think many of you who heard that were inspired by where that vision could take us. And many people across the state who I think are inspired by that vision. My goal is to really talk about what we're doing to try to achieve that vision and how we are trying to do it in a way that benefits the citizens of the state of West Virginia, our healthcare providers, and many other stakeholders that participate in the healthcare arena. Many of us, I think, grown up with the idea that our healthcare system is one of the finest in the world. If you're traveling outside the United States and become sick or injured, you want to get back and be treated by a physician who's been trained in the U.S. and seen at one of our fine healthcare facilities. Unfortunately, the evidence doesn't quite support that notion. Jim Collins, in his book, Good to Great, discusses one of the key principles of the Stockdale paradox. And Collins suggests that great companies have learned the importance of looking at what they do well and also looking hard at what they don't do quite so well. And he calls that confronting the brutal facts. So if we apply the Stockdale paradox to healthcare, really start to uncover some concerns. The first concern that Clay alluded to in his conversation is that healthcare consumes a huge portion of our gross domestic product. Currently about 19% nationwide, closer to 25% in West Virginia. Despite all of that healthcare spending, our health outcomes, including the most fundamental health outcome, which is life expectancy, is actually among the worst of developed countries. And people are just not happy with their experience in the healthcare system. Only about half of those surveyed feel as though our system is good or excellent. In addition, physicians themselves aren't very happy. Most physicians report low morale, and they've increasingly had to focus on the business of medicine and not the purpose of medicine, which is why they started in the profession to begin with. And if we face the facts in West Virginia, our challenges become even more evident. As seen here, we continue to struggle with some of the worst health indicators in the nation for smoking, obesity, preventable hospitalizations, low birth weight babies, poor mental health, and excessively high rates of cancer, cardiac disease, stroke, and diabetes, not to mention substance abuse that Judith spoke about this morning. All of this results in some very large healthcare expenditures which contribute significantly to our overall state budget deficit. Shown here is the 2017 budget for the West Virginia Department of Health and Human Resources. The total budget for the department being $5.34 billion, with 76% of that budget being allocated to the state Medicaid program. Now, I should point out that obviously the costs of Medicaid are shared between the state and the federal government, with the state paying about $1 billion and the federal government paying about $3.1 billion. And obviously there's a lot of discussion going on at the federal level about how those costs may be reallocated. But suffice it to say that Medicaid, which now provides health insurance for 1/3 of all West Virginians, is a huge part of our state budget. And the other thing that this slide illustrates is that because so much of our expenditures are tied up in the Medicaid program, our ability to support other vital initiatives has become increasingly difficult. So for example, the work that's done by the Bureau for Public Health in tobacco cessation and diabetes prevention, and the work that's done in the Bureau for Behavioral Health, addressing substance abuse treatment and prevention. These are the very types of things, perhaps the most important, that we need to emphasize in our state, but we're unable to devote the resources because of how much money we're spending on sick care. So when you apply the Stockdale paradox to the healthcare system, the brutal facts are that we're not quite as good as we want to be. We also have major public health challenges in West Virginia, which contribute significantly to our economic challenges. The vast majority of our health spending is on sick care, not keeping people healthy, and both physicians and consumers of health care are not very happy with the situation. On the other hand, there are some sectors within the healthcare arena that are actually doing quite well. For example, 11 pharmaceutical companies are listed among the Fortune 500 companies in 2016. For-profit health insurers are doing pretty well in this environment. Over the 7-year period from 2009 to 2016, while the overall Dow Jones Industrial Average increased by about 250%, we've seen huge share price increases among some of the largest health insurance companies. Over 1,000% increase for WellCare, Humana, and Cigna. UnitedHealth reported an $11 billion profit in 2015, and Aetna reported a $734 million profit in the third quarter of 2016 alone. So, we've got some winners, we've got some losers in the current healthcare environment. Some of our hospitals are doing quite well. Others, particularly those in rural settings, smaller community hospitals, are struggling. For-profit insurance companies and pharma doing pretty well. Consumers and taxpayers who are supporting public insurance, not so well. Providers continue to do pretty well, at least financially, but many of them are dissatisfied with their work and their life experience, resulting in very high burnout and suicide rates among middle-aged physicians. And all of this really pretty eloquently captured by Dr. Marsh when he says the business of medicine is rescuing people from failure, while the purpose of medicine should be preventing failure. So the question really becomes, how do we get back to focusing on our purpose while still maintaining a profitable business enterprise? And we're working hard to solve this question in West Virginia, but it obviously is an issue that has national implications. I think that the situation perhaps is most easily illustrated if you look at how primary care providers are paid and what they're being paid for. So our current payment system, the fee-for-service system, pays providers for things like office visits, performing tests, providing vaccines, interpreting x-rays, and EKGs. What it doesn't pay for are things like making phone calls to check on patients, sending out reminders for preventive services, helping people better manage their own diseases, providing nutritional counseling and advice on exercise and stress reductions. And these are exactly the types of things that are needed if we want to improve the quality of health care. Preventive care and quality management of chronic disease are some of the most important things that we can do, yet there's no financial incentive or reward for healthcare providers to perform these services. So that's really the essence of the conundrum. We've got a fee-for-service payment system that's developed over the last 50 years, that has rewarded and incentivized us to rescue people from failure, perform tests, and do lots of procedures, and has disincentivized us from keeping people healthy. Fee-for-service has become, in essence, the sacred cow of our healthcare system, and there are a lot of very smart people that have learned how to thrive well within that system. Unfortunately, it's not working for the vast majority of Americans, and it's not working very well for most West Virginians. So where do we go from here? Well, my friend Dr. Marsh has said that sacred cows make some of the best hamburgers. So let's think about how we might serve up some tasty recipes for change. As we approach this, I think we need to first clearly articulate what's our goal. And our goal is to simply improve the value of healthcare. If we define value as the quality of service that's provided divided by the cost of that service, you can improve value by either improving quality, maintaining or reducing costs, or some combination of quality and cost improvements. By creating savings through that process, you can redirect those savings and investments into actually improving health and well-being, increasing the budgets for things like prevention programs while reducing the amount that we spend on sick care, and doing this in a way that's palatable for payers, providers, and consumers of health care. This is where West Virginia University actually has the opportunity to be a model for the rest of the nation. So let's start with this question. How do we actually control the growth in healthcare spending? There have been a number of efforts already. We know that the federal government tried freezing the growth rate of physician payments through the Medicare program. That didn't work. There have been several cuts of payments to hospitals. That hasn't worked. There have been movements into health maintenance organizations, HMOs, and managed care organizations. That hasn't worked. We've continued to see the escalation in healthcare costs. All of those efforts, in essence, have been blunt efforts to cut across the board and across the system. And what I would like to suggest is that we need something that's much more focused. The right focus is on reducing spending that's unnecessary or avoidable. What you see here is that our overall increase in spending includes growth in both necessary and unnecessary spending. Unnecessary spending, what's that about? This is not fake news. There have been a lot of studies, including studies by the Institute of Medicine, reporting the same thing. Between 20 and 30% of all healthcare spending is unnecessary and wasteful. Think about that, 20 to 30%. Some estimates are that it may be as high as 40%, but it's at least 20%. In West Virginia, with the state spending $1 billion on Medicaid, and the combined state and federal budget being $4 billion, if we could eliminate just half of the wasteful spending that's occurring, we could save $150 million in state funding and $600 million overall. That's $600 million in savings, which is actually more than our currently projected state budget deficit. And think about how those resources could be potentially reinvested in prevention programs, jobs programs, rehabilitation services, educational initiatives, and boosts to our community hospitals where needed. So you might ask, well, where's all this wasteful spending happening? And I would suggest to you that it's everywhere. It's spending for emergency department visits that could be better managed in primary care settings. It's unnecessary or duplicative x-rays or other diagnostic tests, antibiotics and other prescriptions that we give out to make people feel like we've done something for them, even though there's no evidence that there's actually benefit. It's performing surgery when physical therapy or other treatments might actually be equally effective. It's end-of-life care in expensive ICU settings instead of compassionately done in hospice and other settings. And it's an over-reliance on high-tech tests that are often not indicated or even desirable. There's also a lot of administrative waste in healthcare. Time spent on repeating questions from provider to provider, redundant tests and procedures, submitting multiple different claims to different providers, to different payers. The list goes on the types of waste that's been identified. So our goal should be, rather than making broad cuts across the board, let's focus like a laser on reducing the unnecessary costs and avoidable spending. Because if we do this, and we do it aggressively, we can actually increase the amount that we need to devote to necessary spending. And even with an increase in necessary spending, we can extract significant savings from the system. Savings that could be reinvested in programs to keep people healthy rather than rescuing them from failure. So let's apply this example to, let's say hypothetically, the state of West Virginia's Medicaid program. What might that look like? With an overall spending of $4 billion, if 30% of that was potentially avoidable spending, that's amounting to $1.2 billion in expenditures, $2.8 billion in necessary spending. By focusing the efforts on reducing the amount of unnecessary spending, let's say we could cut that down by 2/3 to $400 million in unnecessary spending, which is still a lot. But by taking that approach, you could actually add an additional $400 million in incentives for necessary spending or rewards to physicians for keeping their people healthier, and still have another $400 million to invest in other opportunities. But that's a pretty daunting task. How are we going to identify all this avoidable and unnecessary spending in a way that healthcare providers will agree upon? Because after all, we're going to be stealing their sacred cow. Well, fortunately, there's already been a lot of work done on this topic. In 2012, the Foundation of the American Board of Internal Medicine launched the Choosing Wisely campaign. And the goal of this campaign is to identify tests and procedures that, based upon the best evidence available, are unnecessary. The campaign actually relies upon the medical societies themselves to come up with and pick lists of tests and procedures within their own field that they believe are unnecessary. So far, over 400 of these recommendations have been generated through this process. A few examples of the Choosing Wisely recommendations, each of which can help to avoid unnecessary treatment, potentially harmful complications, and wasted expenses. Not overprescribing antibiotics for sinusitis or other upper respiratory infections. Not performing screening tests for osteoporosis in women younger than 65 or men younger than 70. Not routinely testing for PSA for prostate cancer. Not performing pap smears for women younger than 21 or those who've had a hysterectomy for non-cancer causes. Not exposing children to radiation and costly CT scans when the diagnosis of appendicitis can be confirmed with a much less expensive ultrasound test. Not performing CT scans or MRIs for someone that's had a simple fainting spell. Avoiding CT scans in children with mild head injuries. Not obtaining imaging studies for patients with non-specific low back pain without certain risk factors. Not obtaining screening stress tests for people that aren't symptomatic or at low risk for heart disease. Not doing routine pre-op testing on patients with simple procedures like cataract removals. And not performing cancer screening tests for individuals on dialysis or who may have a life expectancy less than 10 years. The list goes on and on. This is some of the 400 recommendations that have come up so far. So in summary, there's reason to believe that there are significant opportunities in West Virginia to reduce the unnecessary spending while actually increasing necessary spending and investments in prevention programs that Dr. Marsh alluded to keep our citizens healthy. To identify those opportunities, one of the first critical steps is to gather and analyze healthcare data. This becomes essential because these data help us understand where the unnecessary spending may be occurring. And the data analysis is needed not only to identify those opportunities, but also to continually evaluate how we're doing to decrease unnecessary spending. This is one major role for the university, as the state itself has never really had the capacity or the capabilities to do those types of data analysis. So we're working hard to recruit and build a top-notch health data analytics team. We also need data to help us be more targeted and selective in our outreach and interventions for the highest risk individuals, because we know that healthcare utilization is not uniformly distributed. So this is a study that's based on a national analysis, and what you can see here is that 1% of the population consumes over 20% of the healthcare resources, with 5% of the population responsible for 50% of the overall healthcare spending. So again, using our data to identify who is our top 5%, who is our top 10%, how do we focus our efforts on those individuals rather than across-the-board cuts to better control spending would be a much more smarter way to approach this challenge. So let me provide you with a quick summary of what we're doing at WVU, what we have been doing, what our plans are for the near future. We've recently completed a 1.5-year-long process of bringing together payers, providers, and consumers from across the state to talk about these challenges and think collectively about how we could redesign the system in a way that focuses more on wellness and less on sickness. We've established a trusting relationship with the West Virginia Department of Health and Human Resources, and we've obtained the data that they maintain on the Medicaid patients and on our CHIP beneficiaries. We've started the analysis of those claims data to look for unnecessary spending and other opportunities for savings and investments, and we plan to have the first of those analyses completed in April. Working forward, we'll be working with partners throughout the state to think about unnecessary spending and ways to reduce that and invest those savings, and to redesign care processes for win-win-win opportunities, patients, payers, and providers, and to create systems that actually support success and incentivize health and wellness. So, simple process, right? We're going to redesign our healthcare system. It's a big challenge. It's a challenge that requires collaboration and cooperation among a lot of stakeholders. But we've reached a point now where we really have to move forward. We have no choice. The economy of our state and the future prosperity of the state demands that we really make this our top priority. We're committed to leading that charge in West Virginia, and we're looking forward to the day when the headlines read, "How did West Virginia get to be moving from last to first? And how are we a beacon for that movement for the rest of the nation?" Now, I've got some additional detailed slides that are pretty technical, but we can walk through how these payments could be shifted. But I'm going to stop here and maybe invite some questions and comments at this point. Thank you.